All right, well, everybody's getting settled. So first of all, again, jumped into this really quick, but if we could do another round of applause for Wayne, we really appreciate him coming in. You know, fire has always been very interesting for me since I arrived at Myhin, because Myhin has definitely been a early adopter and very heavily into fire. It's still, for a clinician that is not an engineer or anything of that nature, still have to work to completely understand it. But we're doing some really interesting things with it, and some of the folks in-house at Myhin are having a lot of fun with it. I really see it as the future. So. But with that, I'm going to jump into a quick question for Wayne. So this is taking off from something that Sheridan had captured earlier. But so when will we achieve interoperability? What shows that we've had success and we can celebrate interoperability? And I know part of the answer is that it's really levels of success. This is going to be an iterative thing. There are a lot of things going to happen, but we need to get to that next level where we can all kind of jump up and down and say, yay.
Yeah. As you said, interoperability is really a journey. It's not an endpoint. And so things are happening little by little. All the talks we said today have all made, progressive steps towards the goal of interoperability. From my perspective, one of the most critical things related to fire is the Meaningful Use 3 web APIs, with the Common Clinical Data Set being supported by more than a dozen of the major EHR vendors. And so that is a significant change. Now, that doesn't mean that you're going to be able to plug into a fire API within your own provider right now, because each provider has to make it available according to their own time frame. But the vendors are supporting it. And the vendors are already indicating, even some of those that have very active app stores within their own particular proprietary APIs, are already indicating that they want to move towards the fire platform in the future rather than having these. So this is already setting a new level of potential interoperability than we've had before. It's not all the information, but it's certainly a critical part of the information. It doesn't mean that you can just press a button and everything happens automatically. You still have to deal with security, authorization, privacy controls, and everything else. And that's going to make things move along at a different pace. But we are seeing within provider organizations a lot of production fire applications already placed, and the APIs will make a big difference between them.
Great, thank you. And my bad, I'd like to introduce Sharon Cook. Sheridan works at Myhin as well. You want to give a little bit of an introduction to yourself, your title, and thank you.
Yeah, I can keep it. Can you guys hear me all right?
Yes.
I'll keep it really short.
I'm
so
sitting next to you.
My name is Sharon Cook. I have been working with Myhin for, actually it's now 3 years. Started as an intern 2 years ago and transitioned full time. I work a lot in the consumer space, but as a solutions analyst, I work on a lot of our emerging use cases and try to find kind of how the infrastructure can be leveraged and kind of interconnected to develop new functionalities for, I guess, really everyone in this room to be able to leverage in the future for better outcomes. So.
Oh, I'm sorry, go ahead.
No, go ahead.
I was just going to say, so with that, based on the question that you had asked, is there any clarification from Wayne that you would like? Or?
Yeah, actually, I'm glad you lined me up for that one. So I think that there's tremendous opportunities, speaking from someone in the consumer space, in kind of this emergence of fire and applications and devices. And so I'm curious because I think there's an opportunity for both better exchange, but then better bidirectional exchange between patients and providers. And I've heard that there's this implication to then use that type of data that we previously had inaccessible to kind of improve provider, the provision of service to patients, but then there's implications for those that would have access to that information and wouldn't use it necessarily. And so how has the community responded to that? It's really a question to both of you, is when you have this tremendous opportunity coming down the pipeline to have access to that type of data, what are the implications of those who are non-adopting or late adopters in the space?
I'm not sure how to answer that question. You go first.
Thanks a lot. Well, and I don't have an answer to it, but I think it's a question that that I hear people people asking. You know, there's a certain amount of comfort in ignorance to a certain extent. You know what you know what the patient is telling you, you have to work with that. You gather a little bit more information through testing. And when you've opened up the world of being able to discover the information that others have learned about this patient, it's an opportunity and a burden both. And I don't have an answer for it. I think for the most part, people are embracing the idea of better information. But I think that what it really means is that we have to figure out how we're going to deal with the information overload that comes along with it so that I can get the information that I need and that it's actionable and that I can actually take action on it and I'm not overwhelmed by the information and therefore it's not useful to me. Now, as soon as I figure out how to do that, then, you know, we're done and I'm rich, so.
Yeah. Well, I mean, that is one of the problems FHIR is designed to solve. I mean, that's when we look at Smart on FHIR apps. I mean, they're tailored to very specific things, you know, that you're just looking at. The one I showed was a good example. You know, it's not going to look at all data. It's only going to look at that data relevant to that particular application. And so you sort of filter out the unnecessary information. It also handles two-way data communications. Now, the APIs aren't doing that yet because Argonaut didn't tackle that piece, you know. But it actually are applications, FHIR-based applications in place. Duke University's been doing them for collected patient-reported outcome data and putting it back in and using Smart on FHIR. That's where Ricky Bloomfield came from that piece, particularly to be collecting that information and putting it into data. The piece that we have to worry about is that it's going to require a more educated population to work with this information. You know, there are risks involved. One of the reasons why, you know, one of the things I hear is that, well, it's not the vendor's good fault. It's good. Once you put the data in the hands of the patient, whatever they do with it is out of our control, however poorly thought out that is, you know, if they're responsive. And so we've got to be careful with that. There also is the necessity, and we haven't quite gotten there yet with FHIR, we're still working on having a very robust and controlled and accessible consent mechanism. So the vision is that you don't have to, you have to, you know, have access and, you know, be authorized and, you know, have the permissions to read or write data, but you also have to be able to have persistent consent directives and to be able to make those actionable from an application level. You don't have to sit there and ask someone, hey, do you want to show this every time? Basically, the patient needs to set those policies in place and make them persistent. And again, there are mechanisms to do that. They're just not completely mature yet. They're still under a lot of development and testing and comparison. But people are going to have to be careful, and you know, the application developers are going to have to put a lot of thought into this. It's a great opportunity, but it's dangerous.
I want to jump back to the defining success one and get some input and focus on a very specific portion of this, and again, getting into the consumerism space. One of the conversations that I've had with folks both internally to my hand and externally, Aaron and I have had a number of conversations about this, but is when you look at consumer utilization of data and their PHRs and that sort of thing, you know, everyone's always disappointed by the number of folks that are using it. And what I try to, you know, impart when I'm discussing this is that from my perspective, and I'd really be interested to hear folks here and perhaps from the audience as well, but from my perspective in general, regardless of how technologically literate people are and all, really when we're talking about healthcare specifically, at any one time, there's only a small contingent of folks that are really interested in being able to get into finding their health data, health information, payer information, all that sort of thing. It's because it's important to them because either they or someone that they love and they're helping needs to access that data. At the same time, that 10% is always changing because at different times, other people are running into the same issues. And ultimately, it's going to encompass 100% of us because we all have some types of issues, some kind of healthcare problems or whatever that need to be addressed and we need the data. So one of the things I'm concerned about as we look at success is what are the markers for success? How do we do that? And has there been any thought or you know, Wayne in particular, I guess I would ask you, from an HL7 perspective and talking about FHIR, is there an adoption level or a certain, you know, you illustrated the 5 levels, you know.
Sure did.
Is there anything right now that you're looking towards that, again, we could do that jumping up and down, hurrah, for success?
Well, there's so much that can be done, it's hard to say. I can think of 2 different areas of, not that there's a specific level that you say declare victory, but areas of focus that we think are most important. One of those in the area of improving patient safety.
Right.
And that's going to be a focus of the next work group meeting. And so how can we harness this information to make it, you know, to basically help preserve lives, you know, and avoid medical errors. And the other one, it's actually very closely related, is clinical decision support, which is where you get the real benefit. I mean, having the information available is one thing, but being able to act on it towards the improved treatments and so they're very closely related. In the clinical decision support area is, I mentioned briefly the CD hooks area, but this is really where you want to be able to target information, get what you want, and be able to act upon it very quickly, very quickly. And so, you know, we're not quite at the stage that we have made a lot of progress. There are a lot of neat apps out there, but they're sort of more demonstration in terms of being in place. But I think those are the 2 areas of measurement that you look at, because, and we should be able to see that. I mean, sure, it'd be nice to be able to, costs are a much bigger issue to deal with, but we should be able to be counting how many lives are, you know, lost due to medical error and do better to measure that. And we ought to be able to figure out making better decisions so that we're using better treatments and people are responding better. And so I see the whole environment moving in those areas, and those are the measurement areas.
Well, and it gets really into the analytics and establishing benchmarks and being able to mark the improvements as they develop. So again, within our industry, we're not always really good at that, and so I would encourage, you know, that's one of the things that we need to do. Sheridan or Rim, would you like to add to that?
Well, the one thing that I would add is that I think that we need to caution, I think that you're exactly right. It's something about outcomes needs to be what we focus on. What we can't focus on is adoption or the movement of data. And that's what we've used as measures in the past. And if we're going to depend on that, then we've already reached success, because we're pumping care summaries out all the time in huge volumes. And I don't think that any of us believe that we've reached success yet. So I think that we do need to focus on outcomes, and outcomes are where we're going. That should be what our goal is anyway, is the outcomes, not the movement of data, but the improvement of healthcare. So I think we do need to make sure that we concentrate on outcomes in some way. Good.
I think I might agree with you and disagree with you both at the same time. So I think that the end goal obviously is outcomes and improving patient care, but things like improving the quantity and the quality of data are stages and not necessarily the goals that lead up to. So you need data to get essentially transported. You need it to be good data so that you can interpret it correctly, so that eventually it leads to outcomes. But it's an oversimplification of, yeah.
Well, I think those are implicit in being able to make progress in those 2 areas. If the data is not good, if the data is not accessible, you're not going to be able to make progress in those areas. And the other thing is more and more data is available, we really do need to focus on really having the system be more proactive in telling us what we need to know, rather than having to try to absorb all that stuff. And physicians can't do it. Physicians hate these CCDs because they're just too hard to operate. They just want to, you know, usually they just want to know a few basic questions, and patients do too. Patients should be able to be alerted, especially if you bring in patient-reported information into the picture too. You know, it's like, hey, you know, I wear a Fitbit. Well, if I don't trust it either. The quality of data is not quite there and everything else, but it is a source of data, and there should be the ability, if something alerts the patient, to say, hey, you better look at this, contact a doctor or something. That's where we need to go.
Great, thank you. Another one. Google, Microsoft, and Apple have been mentioned for their role in this. Will it be necessary to have these cross-industry behemoths actively participate and help drive robust interoperability, or not? Any thoughts?
I think it's pretty important. They have so much clout in the world, both in terms of reaching people and in terms of resources, that you know, it's really important for them. They recognize the opportunity. They're getting in that space. Both are kind of shall we say, are not terribly transparent about what they're doing for understandable business reasons, which we get that. But, you know, I think they are the ones that have the capabilities of making major change and reaching large numbers of people more than anyone else.
Well, and I think, you know, from my experience, I spent a lot of time with Microsoft back during the early Health Vault days, and they went in a couple of different directions with healthcare, and for a while there, they almost shut down their healthcare operations and really became much more of in a supportive role. But they are starting to reach out, starting to do more things, and like you said, we're not even close to aware of what they may be doing. Google, I think, is a little more transparent and has had more success. But I agree with you. I think that the more that Google, Apple, and Microsoft are you know, on board and helping to facilitate this, the better off we are. Any other addition to that?
I would say the thing that, as an observer, as someone who's trying to learn from the market and learn where it's going and then try to respond to it with the functionalities that we help with providing them at MyHin, it's been an unusual trajectory, at least in those spaces, in that when there isn't that transparency, it's not following the traditional curve of, okay, you have an early adopter and then you have the mid adopter and late stage adopter, and when activities go in starts and fits, and when you're not totally sure kind of where large players in the games are going, I think this is one of the industries that it's a little bit harder to kind of track to when we're going to get to that kind of major adoption point.
What I'd like to do, I have a couple more questions that I'll hold out on, but I wanted to check and see if anybody in the audience had any questions for the panel.
I have a question kind of piggybacking on the previous questions. Earlier in the week, we were talking about some of these. Earlier in the week, we were talking about some of the new technologies and economic incentives for using the technologies. And I'm curious, I know when FHIR was first coming out a couple years ago, our CIO came back and said, we need to do FHIR. And I said, well, what do you want to do with it? And you know, we could never figure out what the business cases were for the technology when it first came out and that. So I'm just curious, when you're trying to make the case for embracing a technology like FHIR, are there economic incentives for organizations to embrace it and move in that direction?
Well, twofold. One is, well, you got the ONC challenge grants if you want to get a $25,000 or $50,000 award to show something. More so, it's easier to build applications in the FHIR environment. And so the economic incentive is you can find people who can learn and absorb the technology quickly and develop it more quickly in less time and effort. And as the APIs become more widely available, you're going to, you know, drastically reduce the cost of data integration. So the downside is, yeah, it is an evolving standard. As I said, most of the apps are currently, you know, within an enterprise, except rather than across them. You know, HIEs are bringing in data from multiple sources. We haven't quite seen that happen with FHIR, but I think we will over the next year start to see it with the new APIs. But you know, but you can certainly use the FHIR platform and the REST technology and the tools to build tools, you know, no matter what you're getting your data from. There are companies out there that will set up a FHIR server for you for a fairly low cost, that plug it into your environment. And that's a much simpler way to build apps, you know. You can find programmers who want to do it and do a good job. And so that's a significant economic incentive right now as the infrastructure migrates more to FHIR, and that's going to take years, multiple years, you know. Things will get progressively easier, but I think there is an economic incentive already.
Any other questions?
You know, we talk about outcomes being should be one of our drivers for, you know, adopting new technologies to improve outcomes. But with our healthcare organizations being largely for-profit entities, you know, how is that honest, really? I mean, if it's something that costs money to implement and it's not necessarily improving the claims process or increasing claims, and if you're improving outcomes, you're actually decreasing usage of health services, you know, where does it all come to a head? The 20,000-foot question, I don't know.
Yeah, well, yeah, I mean, it's kind of hard to see where that goes, but the first thing is you can't measure outcomes without access to information, easy access to information. And so the things we've done with the value-based care community is trying to figure out what can we do now that we have this capabilities emerging of being able to use clinical data more effectively. How can we measure outcomes? In terms of what it does to the overall healthcare environment, that's kind of hard to project. We certainly hope it brings down the cost of healthcare. You know, we certainly hope it actually has people get better treatments they're getting now, but it's a little too, you know, we'll have to see where it all goes. That's the goal, and I think it's absolutely important to pursue it, but, you know.
Well, and I think that one of the important things there is that, to a certain extent, I'd say that you're right in the current environment, but the healthcare environment is changing. And we really are moving, I think, we really are moving towards a risk-sharing environment where it's not all fee-for-service, that there's value-based payments that are coming. I know that that's happening at Medicaid state level in a lot of places now, and it is in the financial best interest of the provider community to also have better outcomes. And so I think that this is merely, the information is going to be merely enabling for the cost savings that absolutely have to happen for provider organizations as well.
Well, and I may take this a little bit of a different direction, but again, as Rim was saying, you know, when we start getting into risk sharing and as we're talking about, you know, ACOs and other different delivery models and all, we're going to be reimbursed differently. And so, you know, we are going to have to prove outcomes. Now, at this point in time, most of the outcomes are limited set. It's following, you know, the different quality measures that we have at this point in time. And when we talk about quality measures, and this has been somewhat the bane of my existence as a family practitioner, the quality measures, if you know, look at it, that we're being measured against are about this much of what I do, which is this much. And so, you know, we're going to see this expand. So the quality measures, as they're, you know, discussing next door, you're going to see them grow broader and broader. So it's incumbent upon us to be collecting the data that's necessary to be able to put those measures out. And as a result of that, then we have an opportunity to, you know, that data is there. We're going to be able to work the data and be able to assess it and produce those outcomes and comparative outcomes to look at how we're doing today versus what we were doing a year ago or what we're doing a year from now. So, you know, it's incumbent upon all of us. We're going to have to do it. You know, we have the capacity now to collect the data. And that really is, it's a key number one thing right there. But as we get into a much more interoperable environment where we're able to collect data from multiple different sources to be able to do this assessment, you know, we'll get those outcomes and we'll be able to show whether or not it's working. And if not, then we set the next quality goal and we head towards that and see if that helps improve. Does that help answer the question at all, or? Okay. All right. Good. Yes. Oh, good.
Sorry, one more question. We've talked a lot about the ownership of information and the not wanting to share. I've been waiting patiently to see how the Veterans Administration feels about all of this. Are they going to share their data?
So quick answer to that. VA has had many initiatives to do so, to start sharing data. And of course, they've, you know, worked between VA and DOD to establish, you know, movement of data, and they're, you know, moving towards a common, you know, tool, you know, to use, which will obviously help out a lot. And there have been a lot of attempts in the past to start working with more of the private and non-governmental sources. But I haven't seen a whole lot happen other than some pilots where it's happened on any kind of a large-scale basis. I don't know, anybody else on the panel seen anything either that's transpired to this day or coming in the near future?
Well, the VA was one of the first initiates for Blue Button. So in terms of ownership of data and believing that consumers should be able to have access to their own data, they would allow veterans and their families to download their medical information in the portal, which can then be shared with other members. But that's the only thing I could speak to today. Personally benefited from it. It's still alive and well today.
Everybody keeps looking at me.
No, I'm
You
just
said blue button.
giving you the opportunity.
I'm hesitant to wade in on this, but because what I would say is that a lot of the issues surrounding the VA don't have anything to do with technology or anything else. It's processes and the mechanisms for sharing data internally don't adapt well for crossing the VA boundary into private sector. And as an example, that the average VA provider is not authorized to send PHI outside of the VA system. Mm-hmm. It's a policy issue. It doesn't have anything to do with technology or capabilities or anything else. It's a policy issue. And that can only come from administrators within the VA instead, which are not the people that are actually needing the information or want to send the information out. So it's a people, policy, and process problem that is the issue there. Fire isn't going to fix it any more than any of the other things we've talked about. It's a process issue.
The only thing I have to add to it that is a positive direction is there an increased awareness and sensitivity out there. Consents are getting a little more broader to sort of like people are actually authorizing their data more. People are willing to share their data. It's not really, it comes down to the patient. And so I think it's trending the right way, but there's a lot more to be done. Yeah.
And Blue Button is an example of that. I had said earlier today that I wasn't a huge proponent of patient-mediated exchange in the VA system. That is probably the simplest way to make it happen, is that veterans do have good access to their information if they will get access to the portal, and they can share it then however they want. But the VA somewhat depends upon that mechanism, which I think is unfortunate.
And this is an area where I think FHIR will help. Again, my background's from clinical research for the pharmaceutical industry. And you know, there are a number of reasons why they don't really use EHR data. They require everyone to enter data into a separate system. That's the historical legacy. But with the advent of web APIs that make it possible for patients to access their data, you can do an informed consent with the patient that they grant you the right to use their data, whereas the institution be more reluctant to do that. And so that's the patient-mediated thing you don't like, but it's basically opening up that up. If we can make it easy for the patient to say basically, hey, I'm basically enrolling in a clinical trial and you can use my data. I want you to use that. And you know, the flip side of that is that the patient to get that data back too, so it becomes part of their permanent record. And that never happened before either. And so, you know, I think particularly people with serious diseases are very willing to share, because even if it can't help me, maybe it'll help my descendants in something. So I think we're getting closer to the point where patients can actually, you know, have more of a say in the matter, where that really hasn't been possible before.
Right. And I think that even though we're always a little hesitant to feel like, okay, how much responsibility does the patient have in exchanging their data, I think they've always kind of indirectly been considered kind of interoperability version 1, right? They're the middleware between one provider and another. Even if that's not where we want them to be in the future, I think it's kind of that pragmatic approach to getting data at this point in time.
Thank you all. Any other questions out there? Sure.
Measures. Outcome measurements are not necessarily the same thing as clinical studies, which are more robust. And as there's a push towards seeing better outcome measures, where does the line fall between improving the statistics versus improving the care? I've heard some anecdotal incidents of people who were sent home to self-observe instead of being admitted to the hospital, when perhaps they should have, because the hospital doesn't want to see that readmission. And certainly with the VA, there was information coming out about how the statistics were improving, but the care was not. So on the caution side, I think about those things. On the positive side, I also know that sometimes the process of observing a thing changes the nature of the thing. Like when your kids are being bad and you watch them more, all of a sudden they're not being as bad because they're being watched. And patients who are being given dietary counseling, if they're given a sheet of paper, they may take it home and never look at it. If they're given counseling, they may be more likely to think about it because it's not just a piece of paper. But if you ask them to type everything they eat for 3 days into a website, now that may actually change their behavior instantly, because if they have to type it in, they may choose not to eat it. And so as you're looking at measuring outcomes and observing things, how much are you taking into consideration that observing the thing may change the outcome at the outset rather than as a result of the subsequent care.
Good point, very good point. And in fact, you're spot on. Statistics don't necessarily tell a story. And so if you have a congestive heart failure patient that shows up in the emergency room and they're 10 pounds heavier than they were 20 days ago when they were previously discharged, and they're put into a observation, 24-hour obs, situation where they're rapidly diuresed to get them out of the hospital so they're not readmitted, where they're not going to get reimbursed or for the first one, then obviously that's a statistic that's to the positive in that they weren't readmitted. The other side of the coin is what kind of quality of care was that for the patient? What is their risk at that point that they did not get the proper care at that point in time? So, and I was taking a rather narrow focus when I was talking about the quality measure aspect. But I think the point is that we are gathering a lot of data, both in, obviously, we're capturing clinical data, we're capturing financial data, we have the opportunity to be able to do that analysis. And whether it's done internally or if there are other folks that are able to support us in that. But I don't know, does anyone else want to speak to her question?
I think you make a good point. Prior to my life at MyHin, I was helping Mayo with some research on the impacts of sending patients home with wearable technology to track mobility and trying to determine whether or not it was a technology that was easy to use and could potentially prevent, by kind of tracking over time and examining trends, prevent readmissions. And so I think that maybe a marriage between what you're saying is how do we work towards this goal of the outcomes that we want in clinical research while reinforcing a behavior and tracking at the same time. And so I think that there are examples of it being done and it being done well, and there are examples of it not being done well. And I think that we just have to kind of learn from the first of the two and try to incorporate that into the practices that we employ at hospitals and the way that we use the technology.
At least one thing to perhaps think about a little bit. It's a really good question. I really hadn't given it much thought, so I'll probably say something really stupid here. But if what we're doing is moving to an environment where there is more granular information that we're exchanging and collecting and analyzing, perhaps the fact that you're watching something at a more granular level and changing it is a good thing. Maybe that is more important than measuring the outcome itself, but ensuring that the right thing is being watched. And the right thing isn't necessarily admissions to the hospital, but is something more granular about the care of that cohort of patients. And at least some of what we're talking about here is the ability to measure something more granular, more outcome perhaps is the wrong word. Maybe it's something along the path of treatment as opposed to the final answer. I don't know. That's a good one to think about.
I think you put your finger on it with the children example, actually.
Yeah.
There was this famous study that Dan Ariely talks about where I think it was like in a public office where they had the little box for the coffee contribution jar or something like that. And they tried various different signs, to try to get to, and just watched what was happening. Were people really putting the dollar in the jar when they got the cup of coffee or not? And there was just, I think I don't remember exactly, I probably got it wrong, but I seem to remember the sign they had to put a picture of an eyeball on it. And that suddenly increased compliance by an enormous amount, just because people thought they were, that they might be watched, or somehow it just triggered something in the mind. And that's kind of what happens when you make it more easy to access information and have the possibility of transparency. I think that will have an effect. And I think that will help. That'll actually have an effect on quality. It'll have an effect. People think twice about what they're doing. And so it might be ridiculously optimistic, but that's how I feel.
Thank you. Anyone else? Well, I know we're getting towards the end here, so I'm going to throw one last question out to everyone with a follow-up on it. So Julia Milsing had posted a chart, a graph, indicating the biggest barriers to adoption of the technologies to be work towards interoperability. And there are a number of things on there. Certainly there was workforce in terms of having the resources and retaining them. We had policy and other governmental aspects. Cost is huge. So moving forward, what do you think is going to be the biggest barrier, in your opinion, towards achieving that next level of success that we've agreed, we need to attain for interoperability, so we can, again, jump up and down and say hurrah? We'll go on through. Wayne?
I think it's resistance to change, inertia, and fear as usual. I think the technology's not the problem. You can say we don't have the policies, but you can fix that by creating them. Mm-hmm. So it's just, yeah.
Okay.
So I'm more curious from a learner's perspective, but I think the easy answer for me is making sure that our competitiveness doesn't get in the way of kind of collaborative progress.
I tend to come back to the same thing over and over, and it's workflow issues. I was actually surprised that workflow didn't show up higher on her chart than it did, and it's it's anecdotal evidence that I would be quoting, but I was so struck. It was early on in my work with the Santa Cruz HIE, which is one of the older. It's not a huge organization, but it's been operating, exchanging data for I think it's over 20 years now. Right. And talking to one of the physicians about why they were bothering to actually they were paying for the development of the technology at the time, the providers were, and why they were doing that. And it's because the physician told me, well, I actually see 2 more patients every day and I don't take charts home at night anymore. And it was because somehow they'd figured out how to make it work in workflow, and for those reasons, all about interoperability and electronic information, and it's because they could make it work. And I think the places where we are seeing it happen is because we figured out how to make it work within the workflow, or a small adjustment in the workflow made the system more efficient. So I think it's figuring out the workflow.
Okay. So now I'm going to turn that around and say, what do you think is going to be necessary to, oh no, this is, and I'll contribute as well and help out there, but what do you think is going to be necessary to move the needle on this? Wayne, in your regards to inertia, is there anything particular you think that has to happen to be able to drive this, or there's something that could help to drive it?
You always make me go first, but it's okay. I think, again, it kind of trends back to what I said about the fire community to me. And I know I'm talking about fire, but that's what I was here for. So it just happens to where I spend a lot of my time. And I think part of it is bringing in new people with new insights, willing to think differently to contribute to the problem. I think within the world of healthcare, it's been hidden and controlled by very few. And so going back to, it's just like, we need the young people coming out of school with lots of ideas and energy, sit there and attack the problem, who aren't afraid of it. They can see, hey, we can make a difference, And whereas, us older guys tend to be entrenched in our ways, resistant to change. And so I see that happening. It has to happen. We know it's not sustainable, our healthcare system. And so we need to do that. So that's my answer.
Well, I know you think so well on your feet. That's why I go you do first. So, all right, Sheridan, your thoughts?
I think in terms of collaboration, I liked what Dr. Adler-Milstein said about kind of being too myopic when we're thinking about data being the asset and that stopping the sharing of data. I think that if we're aligning, we're saying, okay, once we have kind of better exchange of this information, we can look at how we can add value to it, how we can interpret it and improve outcomes. I think that's, if we're aligned there, and even if we're still competing there, it's still going to kind of progress us in the space.
I think it is some flavor of effective user demand. I think that we as consumers have thrown up our hands. The system is broken. There's nothing I can do about it. And consumers are not noisy about not getting what they want. And I think to a certain extent, providers aren't demanding enough of their vendors. Right. And in some cases, they're even afraid to demand of their vendors. And I think that users on both sides of that need to be more demanding, and there needs to be some effective demand.
So I'll take this and maybe we can finish it off with this. But from personal observations, again, I've been involved in this arena for quite a long time. And one of the things that I have observed early on, especially when I was doing some of the SDO, Standards Development Organization work, was the people that were at the table. And the people at the table at that time was very heavy with vendors, very few clinicians. There were a fair number of technology folks, and there was essentially veto power. And as we went through our gyrations of trying to pick where things needed to go to keep a focus and all, that if it became too hard for folks to be able to do what the standard was going to require, that all of a sudden it just kind of disappeared off the table. And it was frustrating. And so as I was speaking to physician groups, I did a lot of that around that time, I indicated my concern, that I was afraid that we weren't policing ourselves well enough from the vendor community, and that we weren't getting that input we needed from the voices that needed to be heard, from the users, from the consumers, from clinicians, from others, and that as a result, we weren't making the move that we needed to, and that government at some point was going to step in, and that they could step in at a very light level and start, with some minimal requirements and mandates, or they could step in very heavy and drop the bomb on us. And I'm not sure where meaningful use fell in that, probably somewhere in the middle. It was pretty heavy-handed, but there were some good aspects to it. At least there were some incentives behind it and all. And I almost feel like we're kind of in the same situation right now, that we're getting a lot more voices involved, but maybe we don't have the real clarity of direction and the focus of what it is that we really need to jump on. And I think there's some good things that we've talked about today. Fire. I mean, I think Wayne did a great job talking about fast healthcare interoperability resources and what that means, and the fact that it's something that should be easy to implement, that it should save time and money and all that. So I'm really glad to see where fire is going. I do, Sheridan and I were sharing, some thoughts earlier, and this is I think the third conference that we've been talking about fire, and we're still ahead of the curve. And when is it going to be robustly adopted? Well, I think, from the presentation, we're seeing that things are definitely moving in the right direction, so we're good there. And then, Rim, what you were saying in terms of the participation from consumers and from providers, we need to be the drivers behind this, because again, we're going to be the end users. We're the ones that we're hoping to get the benefits for it. Certainly everybody else, all the other stakeholders have their own part of it, but when it comes down to the end, it's still clinicians delivering care to patients and trying to do it in the best manner, most efficient and least costly way that we can. So our voices need to be heard, they need to be strong, and so I would encourage folks here in the audience to participate, because that's the only way it gets done. I will tell you that Wayne was mentioning John Halamka earlier, and John and I have had a few opportunities to engage, and one of them was when I was at NIH. And I was sitting at a massive discussion about standards. There were, massive, 400 or 500 people in the audience. And John, in his way, he was in his nice black turtleneck with his headset on and strutting the stage, kind of the Microsoft kind of thing. And he just stopped. And he looked out there and he goes, "I want to see a show of hands. How many healthcare providers are out in the audience?" And there were probably about 40 of us that raised our hand. He goes, "Okay, how many of you are doctors?" And there were maybe about 15. How many of you still see patients? So here I was at NIH in Bethesda with 400 or 500 other people that are making decisions about what was going to be delivered in the healthcare arena, and I was the only one that was involved in that actual aspect of interacting with the patients and being able to bring that perspective. And it really was a very, very consistent theme, and unfortunately, As I alluded to earlier, I only had very little SDO experience. Why? Because I had to be funded externally, because it wasn't my job to do that. So my organization was funding me, and unfortunately that funding ran out, so I wasn't able to continue. And maybe I wasn't the best person to be at the table, but again, this is a encouragement for activism, for participation, whatever. Get out there, participate in this. HL7 is very easy to be able to be a part of, and if you can get your organization to help fund you to participate in some of the sessions, that would be wonderful. So. With that, I want everyone, good round of applause for the panelists, because this was an impromptu job, and brought them up here, and I put everybody on the spot here, and so I'd really like you to thank them. And with that, our master of ceremonies, David Levesey, had to catch a flight, so I guess I'll maybe, or Sam, do you want to give the big doors are open, you can head on home now? No? Okay. Yeah. Thank you, everybody, for your participation. It's been wonderful today, and I'm glad you were able to participate. Thank you.